My honor and my pleasure tonight to be one of the panelists for this unique specialized webinar tonight from Spain to Saudi Arabia to here in Ireland. It is my pleasure to introduce one of the top speakers tonight, Dr. Naglaa Hussain, and she is medical doctorate from Al-Qasr Amainy Medical School in Cairo, and she earned her European Development Clinical Nutrition ESPEN, and she is an aesthetic consultant in Northern Border, Saudi Arabia. On top of that, she is a lecturer of Anaesthesia Menoufeia University and in the Liver Institute, specialist in the liver transplant anesthesia. All floors for you, Dr. Naglaa.
Thank you, Dr. Saad. Thank you very much. First of all, my endless gratitude to Allah Almighty for gracious guidance and support. And with my deepest and sincere feelings, I would like to thank Professor Dr. Khaled Yassen, Professor of Anesthesia in King Faisal University, for his guidance in all my life, and especially for making one of my dreams come true to speak side by side with a humble professor like Dr. Javier Garcia, a professor of anesthesia and president of Spanish Society of Anesthesia Madrid. Recruitment is a very important topic. I call it the hidden hero, because by minimal knowledge and application of it, we can manage to prevent a great complications. Okay, a great complication, almost all, and it should be a language all of us should be talking, the recruitment. I would like to declare no conflict of interest to this subject. I hope all anesthesia and ICU as a staff interested in ventilation to be able to speak in a common language of lung recruitment. My agenda will talk about anesthesia and surgery, effect in the functional residual capacity, recruitment, past, present, and future, different methods of alveolar recruitment maneuver, optimal beep and open lung technique, effect of alveolar recruitment maneuver in the hemodynamics, and a cardiometry, new non-invasive hemodynamic monitoring tool. Researches and publication about it, and a take-home message. Functional residual capacity is decreased during general anesthesia and a supine position due to upward displacement, as we see here. Let me open my laser. Okay. As we see here, loss of sympathetic tone, use of muscle relaxant, loss of muscular tone, and moreover, the use of the abdominal retractors. All these factors causes decrease in the functional residual capacity, up to 50%, as seen in this diagram. And this is a CT scan showing the 3 lung zones while supine position. The upper lung zone is normally aerated, and the middle lung zone is partially aerated, while the lower lung zone is totally collapsed. At this diagram, we can show that 50% of the functional residual capacity between a pre-induction period and post-induction period is decreased and slightly increased while PEEP is applied. It's not only the matter of PEEP, as we see here. It's about the period of the PEEP applied. So no PEEP applied, functional residual capacity decreased, and if we apply a PEEP and keep it for a time, so that our functional residual capacity will increase. This picture, as shared by Dr. Khaled Yassen, also showing the volume of the lung when we apply recruitment to the lung, even in the presence of these 3 abdominal retractors. Now, let's talk about the alveolar recruitment maneuver and highlight how it started, where it reached. Recruitment by itself meaning is calling for non-functioning or non-participating units at the time of a disaster, just like in an army. It's the past. In the past, it was all about applying PEEP to improve arterial oxygenation, and different attempts were aiming to use PEEP in different ranges. Nowadays, it's not only about PEEP, but it's about timing, duration, and range of the PEEP. So let's agree when PEEP is mentioned, we have to answer two questions. How much pressure applied and for how long duration? An interesting picture here for a rapid lung showing the number of alveoli recruited in the range of the time. Vital capacity, it's a lot of different types of PEEP were being used, and Dr. Gafir told us now it's no more used nowadays, like vital capacity maneuver, PSI, extended PSI, intermittent PEEP, increase, and CPAP, all were used in a different alveolar recruitment maneuver. It's not only atelectasis is a complication by itself. Atelectasis participates in series of serious complications like sepsis, delayed wound healing, prolonged hospital stay, and higher percent of morbidity and mortality. When we try to prevent atelectasis by recruitment, another complication pop up, which is the hemodynamic changes accompanying the recruitment procedures. At this diagram, we can witness the alveolar recruitment maneuver hemodynamic changes in the form of decreasing the venous return, decreasing stroke volume variation, cardiac output, right and left ventricular ejection fraction decrease, and pulmonary vascular resistance decrease, hypoxic pulmonary ventilation, vasoconstriction, and decreasing mean arterial blood pressure. That may causes in a portion of our alveolar recruitment maneuver and needing invasive monitoring like central venous pressure, Swan-Ganz, and pulmonary artery monitoring. It's a dilemma. Apply PEEP or not. With no PEEP atelectasis, with alveolar recruitment maneuver, we may induce parotrauma or volutrauma, with the complication of overdistension, and whenever disconnection, the recruitment is lost and atelectasis restart. That's precipitate to most serious complication, hemodynamic changes, decreasing the mean arterial blood pressure, and as we said in the last presentation. This is why many study researches for the optimum PEEP with minimal hemodynamic changes. We have said that recruitment is a ventilator strategy, which aims to re-expand and preterally collapsed lung tissue and maintain this re-expansion with an optimal PEEP to prevent subsequent de-recruitment. This picture shows complications of applying PEEP on nearby alveoli by suffering from overdistension and hemodynamic instability, while the atelectic alveoli are still collapsed here, are still collapsed between zone of de-recruitment here in the volume pressure loop and the zone of overstretch. There is a safe window. This is what we are searching for. Applying pressure to recruit lung with no complication, optimal PEEP. So by definition, it's the level of PEEP correlating with the point where an alveolar de-recruitment does not occur, and helps in maximizing arterial oxygenation while avoiding overstretch and maintaining hemodynamics in the pressure volume loops. Upper inflection point correlate to the maximum, here we can see it, the upper inflection point correlate with the maximum recruitment we can get. So in the lower inflection point here, atelectasis, and in the upper inflection, after the upper inflection point, we have overstretch. To avoid the risk of atelectal trauma, there will that occur with ventilation at a lower or absolute lung volume, and for sure not above upper inflection point. So searching for individualized pressure according to the lung compliance below the upper inflection point and for sure above the lower inflection point. This is where large number of alveoli are recruited. Why open lung technique? First, it prevents repeated opening and closing of the alveoli, and use optimal descending pressure, prevent barotrauma and volutrauma in high PEEP setting. And the open lung approach with optimal PEEP using the graded rise of the pressure is better tolerated from hemodynamic standpoint of view and balanced recruitment against over distension. Well, all familiar with the central venous pressure and swan gas and invasive monitoring for cardiac output. But what if the patient is not will do a minimal procedure or there is a contraindication for invasive monitoring? The non-invasive modes like electrical cardiometry, the icon, it measures the changes in the conductivity due to the alignment of the RBCs before and after aortic pressure opening, and uses this to drive the peak aortic acceleration and left ventricular ejection time. Only 4 ECG electrodes are applied, at the AB point and the CD point, and then we can get the measurements of the cardiac output, the icon, the stroke volume variation, and the systemic vascular resistance. Researches and publication about this. Here is the PGA, lung protective ventilations for the surgical patients, and the effect of intraoperative lung protective ventilations with positive end expiratory pressure on the blood loss during hepatic resection during a secondary analytic data, they improve. And also we have done this published, alhamdulillah, under the supervision of Dr. Ghaffir and Dr. Khaled. This is a new paper under, under publication talking about using the open lung technique in recruitment, as Dr. Khaled mentioned, for liver transplantation. This is abstract by successfully presented, alhamdulillah, in the ASA Anesthesiology Society in 2019. And the respiratory and the hemodynamic effects of alveolar recruitment maneuver in liver resection surgery, investigating the effect of alveolar recruitment maneuver on lung mechanics and the PO2 during hepatic resection. The impact of the alveolar recruitment maneuver on the blood loss, hemodynamics, and the cardiometry parameters. Control group. We have two groups, the control group with the pressure controlled ventilation mode and ventilatory setting. Tidal volume was 6 to 8 milliliter mercury and millimeter per kg, and the PEEP was 5. And the arm group, the alveolar recruitment group, with optimal PEEP 6, tidal volume 6 to 8, and the arm timing after induction, application of surgical retractor, or any disconnections happen. Using this software in the program, as Dr. Khaled said, installed in the anesthesia machine in General Electric. Cardiometry and CVP were monitored, and hemodynamics. As for hemodynamics, what we have done the recruited maneuver started post-induction of anesthesia by pressure-controlled ventilation, constant driving pressure of a maximum 15 centimeter water, with a step-by-step increase by 5 centimeter in the PEEP every 3 to 4 respiratory cycles, measuring the dynamic compliance till we be sure that the dynamic compliance started to decrease after each step, followed by a progressive reduction in the PEEP step by step with increasing 5 centimeter water, then by increase of 2 centimeter water until optimal PEEP is achieved. We knew it by searching for the dynamic compliance. And the level of which the dynamic compliance decreases abruptly 2 centimeter plus 2 centimeters. Then redo the cycle and starting from the normal PEEP, reaching optimal PEEP as we kept it open. PO2 and PO2 FiO2 measured 20 minutes after each recruitment. Optimal PEEP was reported guided by dynamic compliance and systemic hemodynamics parameters, the heart rate, mean arterial blood pressure, and central venous pressure. Electrical cardiometry parameters were measured. Cardiac output, correlated flow time, and systemic vascular resistance and stroke volume variation were reported. What we found, The dynamic compliance relief statistically significant higher in the Arab group, while compared with the control group in different timing of the measurement. And repeated measures analysis for the PO2 relieved statistically significant higher in the Alveolar recruitment group when compared with the control group. And no significant difference was observed in the cardiac output from the Aram group to the control group. In spite of high central venous pressure was statistically significant higher in the Alveolar recruited maneuver group compared to the control group, the mean arterial blood pressure did not change it, or the cardiac output here, mean arterial blood pressure, or the cardiac output. No significant difference in the mean arterial blood pressure or the cardiac output. No significant difference also observed between both the Alveolar recruitment maneuver group and the control group. Conclusion, individualized arm, individualized alveolar recruitment maneuver and optimizing the beep helped improve lung dynamics complication and overcome the reduction in the functional residual capacity. This leads to a significant increase in the pulmonary in the PO2 with alveolar recruitment maneuver group. Optimal beep does not affect hemodynamics as cardiac output and mean arterial blood pressure like other methods of excuse me, like other methods of alveolar recruitment maneuver does. Alveolar recruitment maneuver by optimal beep does not affect surgical bleeding, and non-invasive cardiometry is superior to central venous pressure in monitoring hemodynamic changes during open lung recruitment. And a take-home message, recruitment should be a common language in general anesthesia, abdominal surgery, type of alveolar recruitment maneuver individualized according to every case separately. Alveolar recruitment maneuver application decreases the incidence of post-operative pulmonary complications post-abdominal surgery, and if, electrical cardiometry monitor stroke volume variation parameters helps in fluid guides administration during alveolar recruitment maneuver while central venous pressure did not. Thank you very much. Hello.
Hello, Dr. Naglaa. Thank you very much for this really very fascinating, well-illustrated lecture and very comprehensive about lung recruitment. Just let me to get some of your questions here. What is the absolute and the relative contraindication of the lung recruitment?
I think Dr. Gafir said it in one of his slides in his presentation. For sure, any pressure applied into the thoracic with another pressure here in the brain, it's contraindicated, like intracranial pressure, increased intracranial pressure, or open lung, open eye trauma. This is an absolute contraindications, and the relative contraindications in the last days were the hemodynamics. But with the new era of non-invasive monitoring, as I have been highlighting, like cardiometry, and Dr. Khaled Yassen highlighted the CardioQ, it's not no, it's and by using the open lung technique, step by step, I think the hemodynamics is no issue anymore.
Okay, the other question is from Dr. Fernandez Campos. If after doing RM, your tidal volume low for some reason, but the beep maintenance, do we lose the recruitment? After we're doing a lung recruitment maneuver, your tidal volume lower for some reason, but the beep maintenance, do we lose the recruitment? I don't know.
Okay, a recruitment is lost when any disconnection happens. This is where you have to redo it from the start. This is first thing. The second thing, if any pressure applied from the inside the abdomen, this is another cause of losing your recruitment. So if you keeping the I think it's will not be lost.
I think
Professor
Fernandez
would like to add something.
Yeah. Yes, please.
Yes.
Go ahead. Thank you.
I think he's talking about something that is very, very, very common to see, is that imagine a normal surgery, abdominal surgery, but not complicated case. You recruit the lungs, you put the right PEEP in the best PEEP. After that, let's say the surgeon starts to operate on the patient, then you can see perfectly how the number of the compliance is changing a little. So this can be two different things. One is when every time that the surgeon is pushing the abdominal cavity, it doesn't mean always that the patient is going for atelectasis. Well, it's exactly the same if you push the thorax or you put the elbow on the top of the thorax. What is going to happen is that dynamic compliance is going down, but it's not related with atelectasis. So how can you find, and the other option, obviously, as you said, is someone disconnected or the patient can go for collapse. How can you know that or make the diagnosis in this situation? Well, the second is the tendency, the trend. If dynamic compliance is going up, going down, going up, going down, going up, going down, but it recovers every 5 breaths or whatever, it means yes or yes or yes, that there's no atelectasis. It's changing due to the movement from the surgeon. But if you see the trends, there are some even some software that is called mini trends that display in the first screen 15 minutes of the light, and it's a very nice graph that they put the PEEP according with dynamic compliance. If you see the trends, you perfectly see two options. First, like it's moving, but it's like a line. This means that you don't have atelectasis. And the other situation is moving, but it's going down, going down, going down, going down. In this case, it's clear that probably the patient is going for recollapse. Go for mini trends or for the trends in the last 15 minutes.
There is another interesting question here. Practically, how many times do you do recruitment maneuver per hour? Is alveolar recruitment maneuver continuous all the operation?
Well, actually, I do it first after induction, and second after applying the retractors. And if any disconnection happens, and if the patient going to ICU and disconnected from the anesthesia machine and to be reconnected into the ventilator in the ICU. Except this.
Okay. We lost your voice, Dr. Naglaa.
Yeah.
Okay.
Dr. Khaled, do you want to comment on that?
Well, she mentioned it clearly that we do it at certain phases during the surgery when we feel that we need to do recruitment because certain significant changes happens. For example, after anesthesia induction, when there is a surgical retractor applied, when we have some sort of disconnection due to suctioning the lungs or something like that, when we transfer patients from OR into the operating into the ICU, then we transfer them with an ambu bag or a portable ventilator, then we have to do the recruitment intraoperative. When we cancel the recruitment because of hemodynamic disturbances, we have to re-recruit them. But throughout our surgery, these were the only phases that we did re-recruitment for. If we, of course, we have hypoxia and it is not working. Okay, any further questions?
I think I don't have any more. There's one more question here. What is absolute and relative contraindication of the lung recruitment? I think
it
has been answered before.
Yeah.
Yeah. If I think we have done everything now.
Okay.
And thank you very much, everybody.
Can I take the chance and ask Dr. Javier very fast 2 questions? Do you use inhalational anesthesia sedation in ICU, like sevoflurane Because it's now becoming more popular, and we already did some research on it in Egypt.
Yeah, I mean, especially now in the COVID area, we are using it. The story is that we don't have that much devices, but we use it. And the limitation is that you cannot use it more than, at least here in Spain, is not allowed it to use it for more than 24 hours. So it's something limited in time. We use it for the cases that we have, because we have seen that you can improve a little oxygenation. And because we have some studies in research that you have less some anti-inflammatory effect. We published in our journal that they have some modulation in inflammation. So it seems to be something useful, but it's very time limited because you cannot use it more than 24 hours.
Are you using the Anaconda or the Mirus?
The Anaconda.
Anaconda. We are writing a review article these days about the inhalational sedation ICU. Maybe if you have your time, we could send you the review, have a look at it, and tell us your opinion. My last question is, in COVID-19, have you tried inhalational antifibrinolytic agents like streptokinase? Have you tried inhalational streptokinase or antifibrinolytic agents?
Okay, yeah, we did, but we really we didn't see any benefits. So now after the second wave here in Spain, because maybe you have heard, in the first wave we use all kind of drugs without any clinical evidence, and it was totally experimental. So there was a huge movement saying that after the first wave, we are not going to use a single drug who is not completely indicated. So now we are not allowed to use this kind of drugs anymore. So the only thing we can use we only can use the drugs who have indication for COVID-19, except is under a clinical randomized trial. So we don't use it now. Because now we are not allowed to use any kind of drug that is not specifically indicated in COVID-19. But in the first wave, we tried even anti-fibrotic, many drugs used for pulmonary fibrosis. But let's say it was not under clinical randomized trials. So I think this type of drug nowadays should be evaluated under a strict clinical randomized trial just to see the outcomes, because I think otherwise it's going to be very difficult to see if it's useful or not.
Okay. I think
Dr. Ghaffar, I have a question. Dr. Ghaffar, I have a question also on Corona. Fortunately, I was responsible here in Saudi Arabia in the ICU for Corona patients. As you have said about the allowable hypoxemia and hypercapnia, actually in some cases I used the Precedex as sedation, and it dexamethasone as a sedation, and it gave me a very as you know that if patient is intubated, so we lost this patient. So to increase the period of the patient is not intubated, I use dexamethasone as a sedation protocol. Do you have any do you agree for this, or you have any like history in ICU using dexamethasone for Corona patients as a sedation to increase the period of before intubation?
If I understand well, what you say, to use desmetomidine previous to intubate the patient, yeah, definitely for us nowadays. Pardon me?
No, not to intubate the patient. Not to intubate the patient. To just sedate him because he have severe hypoxia he has severe hypoxia and air hunger, just to sedate him that he can be non-invasive, to accept the non-invasive technique of ventilation.
Yeah.
Yeah,
Is what I was
she's
saying.
meaning, she wants to say that can we prolong the time before we intubate the patient by using dexmedetomidine?
Well, the important thing, and from the Spanish, there is a very nice. We in this coronavirus we create from SEDA, from the Spanish National Society, a big study. We record all the patients treated by anesthesiologists. We reach 1,300 patients, and the point that we are now analyzing is that the first important thing, non-invasive ventilation is saving a huge amount of patients. So before coming to Spain, I remember that coming from China, whatever, say, don't use non-invasive ventilation. This is a totally wrong message. Non-invasive ventilation is probably the method who have saved more patients, included high flow nasal cannula, if you have this device. So definitely we have to use it. You can sedate the patient, and in my opinion, dexmedetomidine is one of the, is the first election drug to use it. So the story is like, now we are reanalyzes the patient who have bad outcomes. And the story is, yes, if you delay the intubation too much in patients who are under non-invasive ventilation, now we know you have a worse outcome. But be careful, because this doesn't mean directly that the problem is because you delay the intubation. One bias that can be is the patient that never respond with a good immunity against the virus. Because the story about coronavirus is, as now we know that some patients don't really overcome the infection. And you can even test. We have one patient from the second wave who still have virus with active replication after 8 months. So the story about this is like some patients overcome the infection very fast, but other ones never do it. So what I'm saying about that, we have to use non-invasive ventilation, CPAP or high flow nasal cannula, and whenever after apply this, the patient still have a high driving respiratory drive. So a high drive, because the problem about non-invasive ventilation is that it's like exactly the same like silly self-inflicted line injury. So are the patient who have a very high respiratory drive. So if the patient have a high respiratory drive, you cannot allow the patient there. And these are the patients that you have to go for intubation. But be careful with this data, because it's still, I think, it's difficult to say sure that this patient is worse. Say we cannot say is worse non-invasive ventilation for this patient. I think non-invasive ventilation should be the first tool to use. And as the final message with coronavirus 19 is that at the beginning in Spain we have a lot of advice from China, whatever. Don't do. After what we learned is that please treat the patient exactly the same that you've been treated distress syndrome all your life. So because all the things that we've been recommend to avoid, we have known now that it was a false message. For example, humidity. You know why they told us don't heat the air of the patient, and it was one of the worst advice possible. So whenever the patient go for the pure distress syndrome, treat them as you used to treat them.
And what about
actually,
tocilizumab?
I have a comment
What
here
about
from one. Okay, go ahead. Thank you.
Because being in a corona center is very disastering to your mind. So you have to hear from all around. What about tocilizumab? Do you use tocilizumab, interleukin? The use of interleukin tocilizumab.
Yeah, we use it as indicate, and in very severe cases we use like a remdesivir, but really
only severe cases.
Yeah, we still use it, but really definitely from our side, the two most important drugs is corticosteroids. So
Yes.
the most important one is
you use high dose. You use high dose or only 6 milligram. You use high dose 20.
No. This is I mean, we use the recovery study doses. So we use dexamethasone, and we use 8 milligrams because the recovery study with 6 milligrams, there is only one thing. The dexamethasone used in England is a different salt that used in Europe. So it's a little more powerful. So, but let's say between 6 and 8 milligrams of dexamethasone. So it's very low doses at pure anti-inflammatory effect. Please don't use high doses of corticosteroids, because was the first mistake we did in the first wave. The story is like corticosteroids have two actions depending of the doses. If you use high doses, you create immunosuppression, and you need your immune system to overcome the virus. So if you, we have a lot of experience in lung transplant. In my unit, we run all the transplant. So for us to fight against immunosuppression is our daily care. So the story about corticosteroids, that if you use high doses, you are going to depress the immune system, and then you are going to have two problems. First, the virus is going to kill you. And second, you are going to have overinfections.
If you have an immunosuppressed, and if you have an immunosuppressed patient having renal transplantation and in his prograph or anything like this, and just got corona, what you will do?
Good. We try to modulate the doses. So the story with corona, you have two stories. The first, whenever you receive in the intensive care unit, is after usually 21 days. So let's say that in this period, the immune system of the patient is reacting against the virus. So then that's why in the intensive care units, you can use some kind of immunomodulation. So you can reduce a little the immune system, but not too much. So if the patient has drugs for immunosuppression, we keep it in the same level. We don't go for more immunosuppression. We know that this patient that you keep their treatment have better outcomes. So the concept is like you have to reduce the inflammation. You have to reduce the extra inflammation process, but you cannot destroy the immune system, because if you completely destroy the immune system of the patient, then you are going to have the second more important situation, that is overinfection with bacteria. And that's the final reason that many patients die. That is, you have multi-organ failure due to sepsis. So very be careful. We learned that in the first wave. A lot of patients in the first wave die due to high doses of steroids.
Thank you very much, sir. It was a pleasure to be a speaker with you.
My pleasure.
Okay, Dr. Saad.
Actually, there is a little, not a little, a very good comment here from my excellent colleague, Dr. Salma Khalil. She's working in Ireland as well. We are doing dexamethasone sedation to lots of patients more tolerant to non-invasive ventilation, but unfortunately, patient will be eventually ventilated with poor prognosis. So her comment is early intubation, whatever the indication, is the running protocol in our unit. So do you support that, Prof. Kaher? Early intubation?
No, I disagree. No, I disagree at all.
Okay, okay, that's good. Okay, usually a little bit, we have a little bit disagreement. That's fine. Okay, I have no more comment here, Prof. Khaled.
Okay. Then I think we came to the end of this session. It was very successful. Thank you for your time, Professor Javier Garcia. We're looking forward for joint research. Thank you, Dr. Naglaa, for your lecture. Thank you, Dr. Saad, for hosting us. And thank you, Dr. Shahwar, for running the sessions. To all our panelists, we thank you so much for attending, and our attendees who reached almost 173. Thank you, Dr. Nabila Askalani, Dr. Nashwa, Dr. Hala, and Yasser Zaghlour, and Muhammad Ahmed as well. Thank you so much.